Mrs. Kendall said earlier this morning that this bond is mediated through oxytocin, which helps mother and child bond, and which is triggered during breastfeeding. We know, however, that this substance is inhibited by depression, sadness, fear, shyness, shame. So a woman who may have experienced that trauma during her childhood or currently, how can her breastfeeding be affected? We know that trauma is transferred from generation to generation, so it is a generational thing. And how could breastfeeding help eliminate such trauma, help prevent this transfer, transfer, if I may say so, of trauma? We have the honor of hosting an American psychologist, Mrs. Kendall, who is a health psychologist who has been working in the field of trauma and the psychology of trauma for years and years. I believe she's the most appropriate and competent person to talk to us about such things. Thank you very much, Mrs. Kendall. Δεν έβαλα τη ζακέτα μου για να φανώ πιο επίσημη. Ελπίζω να μην σας ενοχλεί αυτό. Αλλά...
We're going to kind of end the day on a fairly serious note, I'm afraid. But I hope you'll find this helpful, because this is something that really is a problem kind of all over the world. But there's a really hopeful picture in here. This is actually my field. I'm a family violence researcher. I actually study the effects of childhood trauma on adult health. And so a lot of the things that we've been talking about today kind of grew out of that research. The reason I started getting asked to talk about this in terms of breastfeeding is because I was a Leche League leader, and they knew I did. Whoops, there goes my cane. They knew I did family violence research, and so they asked that if I would start talking about this because they were getting so many questions from mothers. So these are unfortunately very common experiences, but they. As I said, it's really shaping up to be, even with all the violence and horrible things that mothers can experience, breastfeeding offers a ray of hope in this picture that I think is very encouraging. So I hope that you will not feel discouraged by this. I hope that you will be optimistic. You know, when I look at the health effects of trauma, and they are pretty grim, I'm always optimistic, because I always feel like if you understand what's going on, you can actually change it. And I think that that's one of the things that so many of our mothers are trying to do when they come to us and they are breastfeeding. Okay, so this is something that IBCLC makes me promise today. I've got nothing to disclose. Oh, you got that up? This is actually, I have a website called the Uppity Science Chick. So this is my science chick here with the glasses. My son put these on for me. He told me it was lame, actually. He didn't think it was very cute. But I have nothing to disclose. Okay, so let's start off by talking about one big category of violence against women, and that is what we call adverse childhood experiences. They're known in the U.S. By the acronym ACEs. It actually comes from a big study that came out of the Kaiser Permanente healthcare system, which is a big health maintenance organization that is, where it's been around since like the 70s. They, it's one thing where it's kind of similar in some ways to a nationalized health program, but the incentive is to try to be preventative and keep you well. And so they do a lot of programs to kind of keep you well, and everybody sort of pays one low fee to be involved in this. Anyway, they did a study, and it was the first study that actually showed a connection between childhood adversity and later chronic health conditions in adults. They had 17,000 middle-class, middle-aged patients in it. And it was really one of these sort of shockwave studies. It became kind of this one that became a model for so many other things. And what they first discovered was that you couldn't look at just one type of childhood abuse alone. Like many researchers, Vince Felitti, who was the lead researcher on this, actually discovered that you can't just look at one type of abuse. He was actually mostly originally interested in childhood sexual abuse. That's actually the field that I come from too. And what we have kind of discovered is we've all sort of broadened our thinking about this and realizing that what goes on in a family and a community has a cumulative effect. So when you are considering adversities in childhood, you need to look at all of them. And so that's the framework that he came up with. So I'm going to kind of walk you through what is included in childhood adversities. And the reason we need to know these is because, as I said, they're cumulative. So the more types of these a child has experienced, the more likely they are to have health issues and other issues. So again, like I said, these effects tend to add on each other. Okay, so the first big category is what we call child maltreatment, which includes both abuse and neglect. And so the abbreviations here: child sexual abuse, child physical abuse, emotional abuse, and neglect. And actually, I looked up the statistics actually in Greece on this. I was kind of curious to see where Greece fell in this continuum. There was a very nice study that was actually done just this year. It was published in the Journal of Child and Adolescent Psychiatry and Mental Health, so 2018. And they did a study with 42,000 school-age children at 3 different ages, and they asked them to identify if any of these experiences happened. They used the UNICEF definitions of what they consider child maltreatment. Now, some of this you may not agree is child maltreatment. For example, they included any kind of corporal punishment. And as you know, that's very hotly debated in many parts of the world about whether that's abuse. But it crossed over into some more serious kinds of physical aggression. There was also psychological violence, they called, and that also included things like an emotional neglect. And actually, the numbers for Greece on some measures are actually pretty high. For psychological violence, 83% of the kids actually reported it. Which, again, like I said, it was surprising. Physical violence, 76%, and sexual violence was about 16%. So I bring that up just to say, many of the moms that you're going to work with have experienced some of the types of things we're going to be talking about. It included things like bullying, and there was a whole long list of stuff. But the UNICEF definitions, that's what they used for their neglect, or for their measures. Okay, now another category, and this was kind of related to what we were talking about this afternoon earlier, is this category of a parental impairment. You may not be abusing the kids, but you're just not there because you're caught up in your own stuff. So you're abusing substances. You have mental illness, and that unfortunately includes things like depression. You are engaged in, there's partner violence in the home. One of the things we've discovered is if parents are hitting each other, even if the kids are never touched, they show the same signs as if they've been physically abused themselves. So, it's pretty serious stuff when that happens. Also, are the parents involved in criminal activity? So each of these things that I'm naming, you can obviously see that many of these things co-occur, but each one counts as a type of adversity. Also, losing a parent at a very young age. Either one of your parents dies, or you lose a parent through divorce, and especially if you never see the non-custodial parent again, which happens actually quite frequently. So losing a parent can actually set people up for a long history of things like depression. It's pretty serious. It doesn't have to, but it often does. There was a great documentary years ago about President Abraham Lincoln, who was the one who was the president that presided over the American Civil War that ended up with the freeing of the slaves. But one of the things that they said is both him and his wife had actually lost their mothers at very young ages, and both of them had a lifelong history of depression. And even though that was a show about history, they actually got it right in terms of understanding what the research says about that. Okay, and a lot of people now are also talking about what is the cumulative effect of not only what happens in the family, but what happens in the community. And so many things associated with lower socioeconomic status. So things like, is there violence in the community? We have so many cities in our country where young children have seen somebody shot, before the age of 8 or 9 years old. They've seen somebody shot, maybe even killed. That housing is not safe. That there's food insecurity. You don't know if you're going to be able to eat. And there's lack of access to medical care. And if you think about, many of the, things that are happening in Europe right now with some of the economic issues, they were actually, one of the things that they were saying in this article is that as the economic picture becomes more grim, oftentimes these violence rates go up because you stress families, and that's when it starts kind of showing up. So you can kind of see how all of these things sort of add together. And one thing I think that's important to note is how common these experiences are. I've read you the numbers in Greece. I'll show you some ones that we've found in our data. Now, this is actually from a study in Boston in the U.S., and they looked at two different samples. They looked at affluent, rich suburb outside of Boston, and then they looked at the inner city. Okay, and what things is kind of interesting is, like, especially when I speak with physician audiences in the United States, the comment I often hear is, that's not my population. Those aren't the patients I see. And it's kind of like, well, yeah, I hate to tell you this, but yes, they are. Because even in affluent areas, you see pretty high rates of violence. So they looked at, first of all, they looked at prenatal depression, and you can actually see it's pretty high, actually, in the affluent population. Okay, but look at lifetime abuse. It's almost half. And in fact, it's pretty comparable to what you see in the inner city. And so when people say, oh, this is not my population, it most certainly is. And this is actually what we found in our study. Now, this was actually our survey, and it turned out to be a rather big data set. But we actually were asking initially about mother-infant sleep. But I knew that many things influence sleep, like things like depression. We looked at their birth experience, but we also asked them all the questions from the adverse childhood experiences, and we asked them about some adult traumas. And we found actually very, very, very high numbers. We found actually almost 1,000 women reported rape. So again, this is the largest perinatal sample of a sexual assault population in any of the literature. And the reason I think people were willing to do this is because it wasn't the primary focus of the study. I think sometimes when you make that, a lot of times patients, people refuse and don't participate in the study. But we found very high percentage there. 25% reported contact child sexual abuse. That's exactly what the literature says, 1 in 4. 32% reported that their parents were abusing substances. Now, remember I told you this afternoon that this was a predominantly middle-class sample. Many people actually kind of have this idea that this is something that only occurs among sort of poor people living in inner cities. And you can actually see these are people that are affluent and out in the suburbs, and they're reporting this amount of adversity. 34% reported physical abuse, and 36% reported that their parents are depressed. Okay, and many of them actually reported more than one. In fact, at least half. We have at least 3,000, we're just looking at this data now, we have 3,000 women who reported at least one type of adversity in childhood. Okay, and many of them reported more. Okay, and so we know that especially in that first 5 years are kind of a critical period, but really any time during the growing up period, that abuse and adversity affects a number of systems. And again, this is where one of the reasons why it's important to understand why breastfeeding has a really key role, because these systems get affected, but they actually can be changed. Remember I said that breastfeeding is a very powerful physiological mechanism, and one of the things it can do is basically turn off some of these things that have had a period of chronic hyperarousal. So it can affect the metabolic, the endocrine, the cardiovascular, the immune system, and the HPA axis. And it can actually go in a couple of different directions, depending on what other things happen in that child's life. It's not necessarily a straight line from abuse in childhood to adult problems, adult mental health issues or health problems. Oftentimes there's things that interfere in between. If the child has other support, If the child has, another adult that they're attached to. I mean, these can be buffers against even the most horrific kind of childhoods. What other kinds of resiliency factors does that child have? Does the child have a personality that allows them to kind of like not necessarily take on all of the shame and things that come along with abuse? And so it can go either one of two ways. It can become either high risk or low risk, depending on those intervening factors. And we can look at adversity in childhood as actually impacting us on several different levels. And I think that this was important because this is the piece that I was very interested in. Is, we had a lot of studies that showed, abuse in childhood led to health problems, but nothing in between. Like, what were the mechanisms? How did we get there? Because I think unless we understand that, it's very hard to do anything about it in terms of helping treat people who have experienced these types of upbringings. Okay, so we know that it actually can impact the physiology. It changes physiology. It impacts behavior, and this is probably one of the biggest areas that's been studied with regard to this. And I think it's a rather incomplete, because I think sometimes people tend to sort of blame the victim. They say, well, it's because he's smoking, or it's because he's abusing substances, or it's because he's eating too much. And they don't say, well, why? Why are they eating too much? Why are they smoking? Why are they abusing substances? So the behavior oftentimes masks what else is going on. In my mind, some of the more interesting things have to do with the cognitive factors. What do you think about this? How do you see the world? How do you see yourself in the world? And the social, how does that impact your social relationships and your social support? Okay, and also your emotional development and your emotional health. Do you have depression, anxiety disorder, and post-traumatic stress disorder? We know that, first of all, we've looked at those as outcomes, but they're also mechanisms that can contribute to a lot of the different areas and problems that people have. Okay, so just to kind of give you a quick overview of some of the physiological changes, particularly in that first 5 years, that really is kind of a critical period because the brain is very malleable then. And so these effects can become more global. I mean, one of the things that you see in trauma research is that when people experience trauma as adults, the effects tend to be more focal. It's like you only respond to things that are similar to kind of the event that was traumatic in the first place. But in that first 5 years, they become more generalized. And so then you get these sort of generalized anxiety disorders or a general sort of depressive kind of affect. So there tend to be kind of more general kinds of symptoms. Because again, I said the brain is sort of malleable, and it kind of, especially in severe trauma, can be sort of rewired. So from a physiological standpoint, one of the things you see is chronic hyperarousal. And so often all the systems of the body become sort of on high alert. And again, it's trying to protect you. You see this a lot in people who've experienced combat. That's a very kind of typical symptom. Like we may hear a little, and for us, that might mean nothing. But if you've been in combat, that might mean that a bomb is detonating. You might hit the floor. Because your senses become very, attuned to anything that could put you in danger. So it makes it difficult to do things like sleep. So sleep disturbances are really common. It also tends to lower the pain threshold. And this is, I think, important when you've got a situation where a mom is really exporting a lot of discomfort, but there doesn't seem to be anything that kind of explains it. It could be that she has a lower pain threshold. So you see more of the sort of chronic pain syndromes. This is one area I've done a lot of work in because I find chronic pain syndromes actually rather interesting, just from a research standpoint. So you look at conditions like irritable bowel syndrome, fibromyalgia, those all show when you go in and actually look at, say, functional MRIs and stuff, you actually do see that the pain threshold is lower. What does that mean? That means like a normal sensation feels painful. Okay, that something that would feel like a touch to you and I, to somebody who's been through especially significant trauma, it feels like pain. Okay, an abnormal stress response, we kind of talked about that a little bit today, in terms of that three-part system. What's interesting is also you see that the higher body mass index is associated with trauma, particularly in childhood. Okay, and also, very scarily, preterm birth. Remember we talked about IL-6 and TNF-alpha? During pregnancy, high IL-6 and TNF-alpha, which you see in post-traumatic stress disorder, anxiety disorders, and depression, one of the other things that they do is they ripen the cervix. So if you want to know why depression and PTSD raise the rate of preterm birth by 4 times, this is why. Scary, isn't it? Okay, so let's talk a little bit about the behavior that can be changed. Now, behavior can also be associated with high BMI. I don't think this is primarily behavior. I think what you actually see with this is you have a body that becomes stressed and hangs on to every single calorie because it feels like, this is a time of deprivation and adversity. I better hang on to every calorie. And what's really interesting is you actually see intergenerational effects of this. I actually have a whole talk about this when I show, a couple of American Indian tribes and kind of what happened to them. And you can actually see an intergenerational effect. And then unfortunately, the American government, after they put them on the reservation, came along and said, you know what you guys need? A bunch of white flour and white sugar. And what's also very interesting is you can tie it to lots of different cultural traumas, and you can look at people. You can actually trace things like slavery and see a big difference in BMI. I really do think that some of this is a physiological epigenetic effect, but there can also be behavior that goes with this. Okay, substance abuse. Almost any substance abuse population that you look at, you can estimate probably 70% of them have experienced trauma. Substance abuse does not come out of nowhere, usually. Smoking, same thing, much higher rates. High-risk sexual behavior, same thing. You see people that are having a lot of sexual partners, that are having unprotected sex, that are having anonymous sexual encounters. Oftentimes there's an abuse history there. If you've got a 13-year-old who's pregnant, boy, you better look, because that's not really normal. And what you actually see a lot of times, especially when young women have experienced sexual abuse or even like child neglect, oftentimes they will, they may engage in consensual sexual activities earlier. But it's really actually heartbreaking to hear the stories about women who feel like they can never say no, that this is the only way people will like them. And oftentimes that is the driver behind high-risk sexual activity. See this in men as well. I was a consultant several years ago on a gay men's health project. Now, considering that I work in women's health, it wasn't the most sort of obvious connection, but what they wanted was my trauma background. And I remember when we worked on the questionnaire, they made, when they asked the question about number of sexual partners, lifetime sexual partners, they put a 4-digit field in that. It was back in the days when you had to, specify how many digits you thought the field was. 4 digits, because they did not think 999 would be a big enough number. It's like, yeah, anytime you see that, boy, you better look, because you're often going to see trauma. And also thoughts about suicide. Actual suicide is actually, fortunately pretty rare. But thinking about suicide is not actually rare among trauma survivors. 30-40% think about killing themselves. And again, especially with a perinatal sample, it's something to kind of think about. Okay, and also sleep problems. Sleep problems, they're a physiological aspect, and there's also behavior. Having things like a regular bedtime routine, going to bed at a reasonable hour instead of staying up all hours. That there's a behavioral part of this that also gets influenced. Depending on how chaotic the family is. If you grow up in a very chaotic family where nobody goes to, cares what time you go to bed, they've actually directly related that to things like your high school performance and your grades. Okay, so I mentioned, the importance of beliefs. And I think, again, this is a really important thing. And this is something just to listen to when you talk to moms, because you're going to start hearing it. If moms mention any kind of indication of shame, that should actually at least get your antenna up that you probably got some trauma going on there. Because again, that doesn't necessarily come, like feeling like ashamed, and even things like the act of breastfeeding, it feels shameful. It's kind of like, wow, just listen. You don't necessarily have to probe deeply. Just listen to what they're saying. But, put your antenna up, because there's probably something more coming. If they blame themselves for what happened to them, their attributional style, do they tend to see the world as, a safe place? Or do they tend to see it as something where people are out to get them? Are you an optimist or are you a pessimist? And that actually directly relates to, how well you're going to cope with life's difficulties. Self-efficacy. I actually personally love this variable. We're starting to talk about it a lot in the breastfeeding world. It basically means, do you feel competent to make positive changes in your life? Can you affect the course of your life? Or are you just a victim of circumstance? You know, and I remember actually back in the day when HIV regimens were really, really like difficult. You know, and it's like you had to take this pill at this time and this pill at this time, and it was critical that you did this. You had to do it. They were really hard regimens to do. And yet, if you didn't do it, your viral load went up. Okay, they knew that. And yet, something like 70% of patients did not follow their regimen. They did not take the pills when they were supposed to do. And the thing they found that made the difference was self-efficacy. People high in self-efficacy were much more likely to comply. I mean, this is absolutely a difference between life and death. It's the same thing with complying with medications for diabetes, medication and diet regimen. People high in self-efficacy more likely to do it. People low in self-efficacy not. Where does self-efficacy come from? It comes from the attachment relationship. If you are, as you're growing up as a child, you have a safe base. This is straight attachment theory. If you have a safe base to return to, so you can go out, explore a little in the world, come back to the safe base. Go out, explore a little, come back to the safe base. That is where self-efficacy comes from. Okay? If you don't have that, you're likely to grow up with low self-efficacy. Now, the good news is you can actually change that. These cognitive beliefs, absolutely malleable. But you have to kind of listen for them. And same thing with health perception. Do you think that you're healthy? You know, and I think really related to like birthing and breastfeeding women, do you feel like your body is capable of handling, you know, birthing and breastfeeding? Okay, also this impacts your beliefs about other people as well. Like the internal working model. This is another developmental psych theory, but it's basically how do you frame the world? Do you think the world is safe, or do you think people are out to harm you? And, you know, and if you've grown up with abuse or adversity, honestly, your experience has taught you that the world is out to harm you. And that becomes very difficult because then that translates into mistrust and hostility. And probably all of you have worked with people who you feel like you're walking on eggshells around them because they don't trust you. You know, and they may come at you with a hostility. They may interpret things that you say in the worst possible way. You know, and oftentimes this comes from someplace. And we know specifically this is related to very poor health. Hostility has actually been directly linked. Remember I told you about the psychoneuroimmunology guys? Directly linked to diabetes, metabolic syndrome, and cardiovascular disease. So it's pretty serious stuff. And again, like I said, it really does influence things like your interactions with mothers. Okay, and something kind of related to that is called rejection sensitivity. It's a hypervigilance about interpersonal relationships. You're watching out for people because you know they're going to reject you. So you're going to do it first. And so again, this is the mom that you're walking on eggshells. They kind of take offense at just the, you know, strangest things that you did not mean anything negative about. You know, and rejection sensitivity also related to health. You know, back kind of in the 90s, a lot of the studies in health psychology were done with HIV positive men. I think partly because they could see what was going on with the immune system. And one of the things they found is with this group of HIV positive men, the men who are high in rejection sensitivity, okay, and it's measured with a, you know, paper and pencil test, if they were high in rejection sensitivity at time 1, by time 2, a couple years later, their HIV was more likely to have turned to AIDS. Okay, they had a higher viral load. I mean, that's how much you can measure it. You can actually see what's going on with the immune system. You know, so these beliefs that we have about ourselves and about other people directly impact health. And they will directly impact the relationships that you have with some of the moms that you work with. Okay, so as I mentioned, these cognitive factors really have an impact on the social relationships. And why are these important? Because we are social beings. And people who cannot form relationships with other people tend to be less healthy. You know, and think about going through something as, you know, intense as new motherhood. You know, being able to form social relationships is really, really important. Okay, so one of the things we find is that, you know, oftentimes there's insecure adult attachments, and this can actually even be with the partner. You know, some questions that we asked in our survey was, you know, a couple of indications of insecure attachment was, you know, do you feel like you can trust your partner? You know, do you feel like your partner really loves you? You know, and that could actually very much be influenced. And oftentimes, you know, you tend to kind of find people who've been through similar backgrounds because you recognize it. You know, it's why the child of an alcoholic will often marry an alcoholic, because that behavior just seems normal. And so these relationships often become kind of very dysfunctional. Now, the good news about this is forming a good attachment with a partner is incredibly healing, you know, and actually can change things a lot. Okay, they oftentimes will relate the current relationship, as having lower quality. Higher rates of divorce. I mean, our divorce rates in the U.S. are pretty high. They're 50%, but it's higher. It's more like 70% in trauma survivors. Social isolation, you tend to see this more with men. What we actually see more in women is what we would call the codependent style, or what's called in the research unmitigated communion. It means that you become the support person for everybody else in your life, but it's never reciprocal. And I think that that's kind of a danger sometimes of people in healthcare settings. I do a talk a lot about burnout and compassion fatigue, and this is one of the things that's just kind of it's just a gray area to just kind of watch for, because sometimes people go into helping professions because they want to turn the bad thing that happened to them in their life into something good, and I think that that's excellent. That's wonderful, but you have to kind of watch that you have at least a couple of reciprocal relationships where you support them and they support you. Okay, we do know that low income is specifically related to growing up in adversity, and you can track back a lot of reasons, looking at, things like ADHD, school difficulties, learning difficulties, you can just sort of track it through. People who have experienced particularly severe adversity are more likely to be homeless. And also, unfortunately, re-victimization. It is actually shocking how much re-victimization takes place on college campuses in the United States. And so many of the young women who get, particularly sexually assaulted, have histories of childhood abuse. And, they've tried to kind of determine why, and some of it they think is substance abuse, that sometimes, you feel all this awful stuff about yourself, so you try to self-medicate, and you use drugs or alcohol, and then you put yourself in dangerous situations because of that. You may be at a party and you're drunk and somebody takes advantage of you. Or as one of my friends, what happened to one of my friends is, she was raped as a child, and she ended up being raped 2 more times. One time she went to get drunk with somebody, and another time she went to buy drugs. And so substance abuse can put you in that. But there was also a really interesting study that I thought was absolutely fascinating, and they did kind of like a video game simulation of a dangerous situation. And what they found is the women who had a history of child sexual abuse did not identify the dangerous situation until further into the video game that they were watching. They didn't see the danger signs. The people who didn't have that experience saw the danger signs early. And so it could be that they get into more dangerous situations and they find themselves in a situation where they get re-victimized. Okay, as I mentioned, the emotional factors like things like depression and post-traumatic stress disorder. Depression is probably the most common thing you're going to see. Depression and chronic pain are probably the 2 most common sequelae of childhood abuse and adversity. Post-traumatic stress disorder, you can estimate probably 25 to 30%. Okay, so, a couple of issues with that is, first of all, we mentioned the social relationships. Things like postpartum depression and PTSD can impair bonding. Because again, like I said, remember it's that sort of childhood adversity, and you're kind of repeating that sort of intergenerational transmission. Okay, now I hasten to add, that's with no intervention. And as I mentioned, preterm birth with post-traumatic stress disorder and depression is shockingly high. You can actually see here, this was actually a sample from our VA hospital. It's our Veterans Administration. Okay, so 16,000 patients. That premature rate is probably on the high side. That's with no PTSD. But oftentimes if somebody in the family has been in combat, there's a kind of a contagion effect. But you can see if the woman has current PTSD, her rate goes up quite a bit. And this study I thought was actually really scary. The combination of PTSD and depression increases the risk of preterm birth by 4 times. And as we heard this morning, preterm birth is the #1 cause of infant mortality worldwide. Why we are not screening for this on a regular basis, I don't know. Okay, so what happens, to women if they are pregnant and experiencing adversity or violence? This is where it starts getting kind of scary. And oftentimes the violence is just one part of the whole picture. There could be marital conflict, pregnancy complications, being single or being divorced, living in poverty. All of these things can kind of contribute to that sort of creating an environment which is, creates an environment of adversity for that mother. Okay, and we know that C-reactive protein, which is another inflammatory mechanism, goes up if women experienced adversity while pregnant, and then the child then experienced adversity as a child. By the time they get to be an adult, they have higher levels of inflammation. Okay, and in this particular study, this was in psychoneuroendocrinology, prenatal adversity increased the inflammation for the baby in adulthood by 3 times. Okay, because what happens is there's a sensitization that takes place in that in utero period, and then the baby comes, as baby is born, and as an adult, their inflammatory mechanism is automatically up. Okay, what about partner violence during pregnancy? You know, and I hate talking about this because I think it's just appalling to think about some woman being beaten while she's pregnant. And I will tell you this, from the domestic violence research, we know that this is a particularly ominous sign. If somebody will beat somebody while they're pregnant, that this is one of the signs that is a risk factor for lethal abuse when they actually kill their partner. Okay, so partner violence increases, during pregnancy, increases the risk of low birth weight, complications obviously for mother and baby, and even possible death for mother and baby. And I'm sorry, I'm going to show you a picture that's going to be a little triggering, I think, but I just thought it captured the absolute fear that I think many new mothers experience if they have an abusive partner. You know, to think about what that would be like, that vulnerability. You know, and so looking at also what happens in the postpartum period with partner violence. You know, and a question then, you know, that this study raised, this was published in the journal Paediatrics, is the question they raised, this is all about, you know, like health effects for the children of being raised by abusive parents. But it said, you know, are women who are abused by their partners less likely to breastfeed? Now, to be honest with you, my initial answer to that would be yes. Yes, I think they would be. Okay, this particular study actually found no difference in either initiation or duration, but it was a pretty small sample size. So again, I said I think that, you know, the judgment is still a little bit open. This study from Melbourne, Australia, found that also found with a larger sample that there was not a significant difference between breastfeeding rates for the partner violence versus the non-partner violence groups. Okay, but you did actually find a difference in this study looking at low-income women in upstate New York. But what's interesting is there was a racial difference here. Breastfeeding cessation for white women, but breastfeeding continued, and actually they were more likely to do it if they were black and their partner was violent. And I think in some ways that's a survival, you know, that was a survival tool that we're going to go ahead and do this. And I said I'd really like to kind of explore a little bit more about what's going on here. You know, I met a couple of IBCLCs at the ILCA conference a few years ago, and one of them had actually just gotten out of a very abusive marriage, and she told me, she breastfed all of her children, and she told me it was the thing that saved them. It saved her and her kids. And so I've always kind of remembered that, you know, that even in this horrible circumstance, breastfeeding can actually be really sort of life-saving. Now, this was actually another one looking at depression. This was with Latino women in the United States. And what was interesting is partner violence, which the postpartum depression world used to kind of ignore. Partner violence actually was a better predictor of depression in the postpartum period than depression during pregnancy. Depression during pregnancy has traditionally been the best predictor, and partner violence was even more. And you can actually see the very high percentage of women who were depressed. You know, people always quote this, 10 to 15% of new mothers will get depressed. It depends what population you're looking at. If you're looking at any kind of high-risk population, that number is much, much higher. This was a nice study from Montreal, and it was looking at a group of women. Some of them were immigrant, and they said 15% of them on the total reported partner violence, and it was more common among the lower-income women. But they said the combination of immigrant status and partner violence increased the risk of depression by 7 times. And for the native-born women, it increased it by almost 5 times. Okay, so partner violence is a very, very sort of toxic thing to bring into a relationship. Okay, so what do we know about breastfeeding and adverse childhood experiences? Well, what's kind of interesting is, you know, for a while we didn't know anything about it. This was the first study I found, and the only reason I even know about it is because I followed the principal investigator of the study around at a conference until she let me look at her data, basically, because there was nothing. And they never published this. This was just in the report they did for their funder. But they looked at intention to breastfeed, and they found the sexual abuse survivors had a higher intention to breastfeed. That's kind of counterintuitive, isn't it? You don't really think that that's going to be what you're going to find. Because you would think it'd be lower, right? I mean, I think if you just looked at it on the first glance. Okay, this more recent study actually found that the women who experienced childhood sexual abuse were less likely to breastfeed for 6 months or more But after they controlled for the demographic factors like income and education, that relationship was no longer significant. So in other words, no difference once you control for the other factors. Okay, and they said that breastfeeding, they breastfed at a similar rate. And the same thing with this one from the Journal of Human Lactation. They found twice as likely to initiate breastfeeding among the sexual abuse survivors. Okay, so more likely to. You know, and I think the thing that's important to kind of take away from that is don't discourage a mom. If you find out she has a history, particularly of sexual abuse, find out what she wants to do. Because you know what? She may want to actually breastfeed. You know, and I think sometimes people have a tendency to say, oh, don't worry about it, you don't need to do that. You know, and sometimes that is actually that's the best approach. You know, I always kind of take it, you know, as we go with moms. You know, if you Google breastfeeding and child sexual abuse or breastfeeding and sexual assault, my websites come up. Okay, so I hear from moms all over the place about this. And I think the thing is, we've got to just, you know, like do what the mom wants to do. But don't discourage her. Okay, so this was another one looking broadly. It didn't just look at sexual abuse, it looked at all the ACEs, and they said that women with a history of ACEs were less likely to exclusively breastfeed. And you did see more problems, okay, in the women with a history of sexual abuse in the study. And that, honestly, I can believe, just having talked to a lot of women. You know, it said they may want to do it, they may do it, but it doesn't necessarily mean it's always going to be easy. Okay, and they actually said, you know, for many of them, you know, the breastfeeding could be a trigger for past memories, but also they used dissociation a lot of times. And I've actually had some moms that I worked with long term who actually said that that was actually very useful. They controlled it. They could say, okay, I'll watch TV, I'll read, I have to just not be here. They never liked it, but they thought it was important to do. Okay, and other mothers find it very healing. It really depends. Okay, so this is just another study showing, you know, that the more violence you're likely to experience, the less likely, you know, that breastfeeding is going to go on for a long time. And again, like I said, the combination of adult violence, it seems to be, the combination of adult and childhood violence seems to be really bad. Okay, same thing. I'm going to kind of move along here. Yeah, this is the same thing. Looking at, you know, obviously depression, huge risk factor, especially if they've experienced both. Okay, so a couple of things. What breaks the cycle? Okay, I think this is an older study, but I've never seen another one that I like as well as this. They were looking at people who had experienced severe abuse during childhood. And what they discovered is that there were certain things that meant that this abuse was not going to be carried to the next generation. Okay, so one of the things I mentioned, having one non-abusive adult during childhood. You see that coming up in the studies on resiliency all the time. So if there's one adult, you know, a teacher, a neighbor, you know, a grandparent, somebody who is not abusive to that child, that actually can be enough sometimes to actually help them cope and go on and not be abusive themselves. They participated in therapy at some point, and they had a supportive, non-abusive partner. Okay, so where does breastfeeding fit into this? Now we're going to start getting to some good stuff here. Well, breastfeeding, first of all, it improves that mother-infant interaction, and it stops that intergenerational transmission of abuse. Okay, now you don't believe me. Let me prove it to you. This was a study from Lane Strathern. You can see actually large sample size, and they did a 15-year study. They found over 500 cases of maternal perpetrated child maltreatment that were documented, okay, by the Child Protective Services. Okay, so, you know, mothers abused, 500 mothers were abusive or neglectful, you know, documented by Child Protection. And here's what they found. Mothers who breastfed for 4 months or more were 3.8 times less likely to physically neglect their children and 2.6 times less likely to physically abuse them. I mean, do you think that's a piece of good news? I think that's just incredible news. You know, when people used to say to me, breastfeeding prevents child abuse, you know, I'm a child abuse researcher, and I was like, no, you can't say that, it's too complicated. And then I saw the study. This study convinced me. This is a very good study. Okay, so then going back and taking a look at our data. Okay, one of the things that we looked at is, I mentioned we had 994 sexual assault survivors. Okay, so these are people that reported the most serious type of contact sexual abuse. So it was rape, you know, and we actually had definitions of that, which I won't tell you because they're kind of explicit. But it was rape. So almost 1,000 women, and again with the 6,400 in the total sample. And one of the things that we looked at is what were the rates of exclusive breastfeeding. Okay? Some of those studies kind of paint a little bit of a grim picture, but they have a pretty small sample size of abuse survivors. And this is what we found. They were exactly the same. Does that surprise you? It surprised me a little bit. I thought it was good news, but it surprised me. Look at that. They're exactly the same. So this is the non-sexual assault group. This is the sexual assault group. And look at those numbers. Okay, so then, remember I showed you this morning about the impact that breastfeeding had on all the sleep variables? You know, and how the moms got more sleep, and they had less depression, and they had more energy. Okay, and, you know, when we looked at sexual assault across the board had a negative effect. You know, terrible sleep, reported poor physical health. I mean, all the sleep parameters were bad, more anxiety, more anger, you know, more depression, just across the board, exactly what we'd expect. So then one day, I'm on an airplane, and I thought, I wonder what will happen if I put these two together. So I put the sleep variables together with the sexual assault variables. And this is what I found. And it just about knocked me out of my chair. Okay, so let me show you what I'm saying. Okay, because remember, mixed and formula feeding were exactly the same. Oh, sorry, that's not Greek down there, but that's the non-assault group, and that's the sexual assault group. We put the mixed and formula feeding together, remember, because they were not different on any variable. Okay, so the red line down here shows the mixed and formula feeding. This is the hours that the mothers sleep. Okay, so you can actually see with this green line up here, these are the exclusively breastfeeding moms. You can actually see that they are still affected, but it is significantly less, isn't it? So these were significant interactions on all of these. And you can see this, we published this paper in Breastfeeding Medicine. So big, big difference. And the interesting thing is we found the same pattern on every variable. Okay, so when we looked at minutes to get to sleep, okay, minutes to get to sleep is another one of those important sleep measures. And by the way, I'll give you a little tidbit here you can use with your moms. Ask a mom how many minutes it takes her to get to sleep. 25 minutes or more is a flag for depression. Okay, it's a very non-invasive way to get at that. We've seen that in like at least 3 studies. It's been really consistent. 20 minutes, okay. 25 minutes, that's a warning sign. Okay, so minutes to get to sleep is another one of those things that really predicts depression. And take a look at this. Okay, so clearly they're still affected. Okay, but look how much less it is that with the mixed and formula feeding moms. Okay, and oops, did I miss angry or irritable? We missed angry or irritable. Minutes to get to sleep. Okay, oops. Do we have that one? Ah, here we go. Okay, I love this one. Okay, angry or irritable. Look at this. Look how chill the exclusively breastfeeding mothers are. Okay, they are not getting angry or irritable, are they? I mean, you know, no more than normal. Okay, but look up here. The mixed and the formula feeding moms. And you know what? Honestly, remember we talked about chronic hyperarousal? That's this right here. And you see this a lot with people who have post-traumatic stress disorder who come back from combat. You know, family members will describe this. He's sitting there disengaged, and all of a sudden he flies into a rage over something. Okay, it's that hair trigger anger. Breastfeeding turns it down. Now, when you think about that with Lane Strathern's study, when he said that the breastfeeding mothers were less likely, 2.6 times less likely to physically abuse their kids. Do you think this could be related to that? Okay, I think it's a mechanism. Okay, so what is breastfeeding doing? It's turning down the trauma symptoms. I mean, they're still there. Okay, I'm not Pollyanna, I'm not ignoring this, but it's turning them down. Okay, so how shall we then treat? Okay, so we talk about, you know, this is our substance, SAMHSA stands for Substance and Mental Health Services Something Administration. It's one of the federal agencies in the U.S. But they have actually come up with what they call trauma-informed care. And I think that actually this is just something that I think should be incorporated into pretty much every aspect of healthcare, because trauma is common. I think that's the thing we just need to take away from this. You know, we used to think, oh my gosh, this is so unusual. It isn't unusual. You know, and if you can talk in a down-to-earth fashion about it with mothers in a comfortable fashion, you're going to find they're going to tell you about this stuff. Okay, so it realizes, first of all, that trauma impacts people in a lot of different ways. And this is kind of anytime they come into a healthcare setting. And it recognizes the signs of trauma in clients and families, staff, because again, it's going to be incredibly relevant to how you treat the moms. Okay, and it also, you integrate the knowledge about trauma into all your policies and procedures and practices. You know, and I think actually one area where we do need to really reform is how we treat birthing mothers. I think, we're one of the worst places, a trauma survivor can be in the U.S. is in a teaching hospital when she's in labor. You trot in 10 residents and they all do a pelvic exam, and they don't, say what they're doing. They don't explain it. I mean, it's really, really, really difficult. And oftentimes people who've been through pretty significant trauma are pretty good at going to places where they're going to be safe. Okay, but it also seeks to resist re-traumatization. You don't want to actually add trauma in your medical settings. And I think one thing that's kind of important, what a lot of moms tell us, is they really get annoyed when healthcare providers grab their breast. They really don't like that. They don't like somebody grabbing their breast and putting the baby on the breast. And the moms just tell us that all the time. And I remember somebody actually telling me that in a class they learned that you shouldn't ask moms permission before you do that, because it communicates to the mom that this is not normal. It's not normal. You don't walk up to somebody and say, "Hi, nice to meet you." Right? You get arrested. So, we need to be thinking about, like all the different ways, even if like we suspect that there might be some trauma here, you can behave as if. You don't necessarily even need to know for sure. Okay, so I mentioned, this is one of the things that's really important in terms of like providing good care, in terms of like just increasing oxytocin. But some of the principles of trauma-informed care: creating safety, being trustworthy and transparent, providing peer support. I mean, doesn't this sound like, breastfeeding support? Yeah. Collaboration and mutuality, empowerment, voice and choice, and also being knowledgeable about cultural issues. Okay, so there's just a few things that you just kind of mentioned, especially with birth, that can actually really be triggers for moms. And just kind of be aware of this, because again, like I said, I think there's some cautions we have to have with things like skin to skin. Things like if moms feel very exposed with skin to skin, oftentimes they're not going to get that oxytocin effect because they can't relax. If they feel like they've got to have their shirt open and they're naked and people are coming in and out, so we can give them the option to, first of all, be sitting up more, not flat on their back, but also to be a little more covered. Suzanne Colson's work on biological nurturing found that you can get a lot of those same good benefits with skin to skin when moms are lightly clothed. So just kind of be thinking about it. But also, anytime you have to physically restrain somebody, and also sometimes a lot of moms find the intense physical contact of breastfeeding a little overwhelming. So what I actually recommend in that situation is you ease into it. Okay, if a mom finds that skin to skin is just too much, maybe you cover everything, but you leave maybe a little section, and you have the baby's cheek maybe on this much of her breast, until that feels okay. And then you can have a little bit more and a little bit more. And I think you're going to find that you're going to get a good effect with that. But what to watch for is watch if she feels like she's just recoiling. And you can see this sometimes in pictures. It's like the mom, they're dangling the baby over the mom, or and she's just pulling back, and it's just too much for her. So just be sensitive, and you can just say, gosh, that doesn't look like it's very comfortable. What can we do to help make that more comfortable for you? And sometimes it's just a matter of giving her a little more control over it. Okay, also if she's got a lot of pain, and things like squirting milk can be also a trigger. Sometimes you see this. I see this a lot of times in parenting groups. Sometimes the mom comes in with an abuse history. She feels like she has to be, always loving and warm and all the time, even in her thoughts. And I remember this one mom that I knew from the Leche League, and she actually asked me one time, she said, "Wow, you mean you actually get annoyed when your son throws a temper tantrum in the grocery store?" And I was kind of like, "Yeah, of course I do." And she's like, "Really?" And she thought she was this horrible mother. Maybe it means I'm a horrible mother, but yeah, that annoys me when they do that. Laying on the floor and screaming. It's like, who is that child? Okay, but also feeling like you can't separate. You can't, ever say kind of no. And one of the most powerful things I ever saw was we had one of our leaders in Massachusetts. She's since passed away, but she was severe abuse as a child, severe. And then a birth experience. It was a nightmare. She had a C-section with no anesthesia. When they realized she could feel it, they basically gave her Novocaine, held her down, and finished. I mean, it was barbaric. So you can imagine what kind of issues she brought. So the second time she was able to work with the midwife. She had a VBAC, but she was tandem nursing, and she came in this one day, and she was just frazzled. You could just see. She was just, a wreck. And she said, "I never thought my life would be like this. I got this baby here. I got this toddler here. I got my shirt open." She's just... and the two leaders who were like more senior, they actually said to her, and I said, I'll never forget this, they said, "You know what? You don't have to do this. You can feed your babies one at a time. You can wean your toddler. Your toddler's old enough. You do not actually have to do this. You can be a little more covered up when you breastfeed. And it was the first time anybody had given her permission to say no to something with her body. And it was unbelievably powerful. Okay, I'm going to skip this one. Okay, so just a couple of things to know. That if you start, seeing trauma survivors, and you will, because now you're going to start seeing it. One thing I would advise you to do is don't try to do it by yourself. Bring in other people on your team, because this can be incredible. This can lead to burnout like you can't believe. And if it brings up issues for you, you may need to talk to somebody. You can be traumatized just by hearing about the trauma of other people. Okay, but also too, trying to limit your involvement. I will tell you this, I get a lot of the depression and child sexual abuse cases that come to me, and I have to tell you honestly, it's really nice every once in a while when I get a case of sore nipples. It's like those are pretty easy to deal with, compared to some of these more complicated issues. And I don't do psychotherapy with them. I'm there to focus and help with them with their breastfeeding, okay? Because I will refer. I don't do psychotherapy. I'm a researcher. But, like balancing caseload, doing some normal kind of self-care, and setting some reasonable boundaries. It's like one of my friends was a lactation consultant, and she had a client who had bipolar disorder. And she used to like to call her at like 2 o'clock in the morning. Not because there was a crisis. It was just that was a good time for her. And finally, and everybody kept saying to her, you've got to tell her no, you've got to say no. And finally one night her husband answered the phone and said, this really isn't a good time to call. Can you call back in the morning? She said, okay, problem solved. It was done. But setting a boundary is perfectly legitimate and reasonable. And also to making sure to take care of yourself. Okay, so a couple other things. If you've got a mom who's kind of struggling, this is what we've got to do. Go into problem solving mode. What is it that's making that mom uncomfortable? And again, you don't necessarily even need to know about the trauma history. Okay, you can actually, if you start getting kind of some clues that maybe that's going on, just start asking some questions. What is it that, that's making you uncomfortable? How can we make you more comfortable? And, believe me, I've worked with moms on every single sort of configuration you can think of. Some moms find that they can only tolerate pumping. Other mothers find pumping is horrible. They hate it. Some moms find they have to distract themselves. Some moms find can just get too much. There's just all kinds of variations. So just go with it and kind of find out. And and even in that situation, I don't necessarily even aim for exclusive breastfeeding, even though we know it's protective in a lot of ways. I aim for whatever they can do. And so it's kind of like what I find sometimes too is like maybe they can only do partial for the first baby, but then they come back to you at the second baby and they're ready to do exclusive. So again, we got to kind of work with them. Helping them know what's normal. Sometimes moms are deeply ashamed that they enjoy the physical contact of breastfeeding. They think it's sexual, and to their mind, touch equals sex, and they feel ashamed by that, and they're just, they're mortified by it, and it doesn't help that law enforcement sometimes gets involved. I've been involved with actually a lot of court cases. Fortunately, I've got some clout in the field of child sexual abuse, and so when these mothers have been accused of child sexual abuse, I've actually written letters to judges. I've called courts and said, come on, this is rubbish. There were women who had open allegations of child abuse for like 5 years on their thing. This one woman was 5 years old, and her 5-year-old, she just had a new baby, and the 5-year-old said, oh, wouldn't it be fun, if I just nursed it one more time? And she said, oh, that's a great idea. And she took a picture of it and took it to Walmart to get developed. And it got turned in. Open allegation of child sexual abuse on her thing. And granted, that, taking the picture to Walmart, in retrospect, probably wasn't the smartest thing, but it wasn't child sexual abuse. They had just had kids die in that state, and that's what I said to the judge. And I said, come on, this is ridiculous. She could not go back to being a teacher until that got cleared up. Just that one thing. So, this business about sensual versus sexual, I think it's something that kind of help moms understand that it really is okay to feel that enjoyment of being with your baby, smelling your baby, touching your baby, that sort of sensual contact. Making a referral, very important. Don't get out of your scope of practice. If you've got a mom who needs more serious care, find out who the mental health providers are in your community and make a referral. And finally, this is the other last thing, is, I work in psychology, and I've had to educate many of my colleagues about what is normal breastfeeding. Because I remember one time somebody told me that extended breastfeeding, which is i.e. beyond 6 months, and co-sleeping were signs of incest. And I said, well, the entire nation of Japan then is in huge trouble, because that's pretty normal there. So that's something that we can also do, is kind of educate, can continue to sort of reach out and educate. Okay, so with that, I'm going to end. If any of you are not on my Facebook page, I would actually say, if you're interested in some of the things we talked about, that's my page. That's our actually basic trauma book we wrote. And you already saw the shameless commercial for depression and new moms. So I'm happy to answer questions. I know we're at the end of the day, so I'll hang around if you'd like, and we can ask questions. I'm not sure where we are on time. Yeah, we're a couple minutes over. So thank you very much for your attention. Thank you for hanging in there. I know it's hot, and I know it's been a long day, so I appreciate you being here. And thanks, and I'll see you tomorrow. But please feel free to come up and ask me any questions.
Ερωτήσεις μπορείτε να κάνετε.
Oh, you have a question? Yes.
Κυρία.
If we see a mother who has sore nipples, but we cannot see any apparent cause, if she has sore nipples or painful breastfeeding, and there is no apparent trauma, how can we see if she needs help from a psychologist?
Well, to be honest, I'd be really careful. I wouldn't jump to that until we'd ruled out absolutely everything.
If it's not our business I'm not a psychologist, right. But how can I know that I don't offend her by sending her to a psychologist? Because it's really difficult to tell a mother that she needs help.
Absolutely. Oh, I agree with you. And that's the last thing she probably wants to hear, is that it's all in her head.
But right? What are the questions that might help us and lead us there so that we can tell her that might be helpful?
I think one thing is maybe to kind of frame it as, sometimes people get, their bodies are very sensitized to touch. And it might help to learn some relaxation techniques, and that this is actually really normal for people who have experienced any kind of trauma, even if it's something like a car accident or, even a really difficult divorce. I mean, all of these things can actually trigger these pain syndromes. And to just say, sometimes we need some help to kind of like turn that down, and sometimes antidepressants can help with that. But yeah, I'd be really careful to make sure you've ruled out other things. But I think I would frame it as more like a relaxation, because I think that's going to help actually, because you've got that sort of hyperactive, and what you want to do is just kind of like tone it down. So that she's more relaxed. So I think that would be probably the way I would frame it. And not, we need to delve into all this trauma stuff, but it's kind of like, what can we do to help you cope with this symptom?
Or could it help the other way? So if we see a mother that is in pain and suggest her to find ways to relax and see that she gets better, could that mean that we might help her find ways to desensitize herself?
Yeah, I think actually, again, like I said, some of the things like mindfulness has actually been really helpful for this. It turns off that sort of hyper arousal. So that would be, again, like I said, that would be like mindfulness, cognitive therapy. Those are really helpful. It just in that very focused, like dealing with this one symptom. Okay, so you're not telling her she has to deal with all this other stuff. But trying to focus on kind of turning off that stress system. That would be the thing I would kind of recommend. Exercise can be good for that too. But again, like I said, make sure you've ruled out all the other stuff.
Thank you.
Oh, you're welcome. You guys need to go. Oh, wait, do we have another question?
Εγώ θα ήθελα να ρωτήσω αν είναι πρόβλημα για ένα νήπιο να αποκοιμείται.
I'd like to ask you whether it is a problem to allow children to fall asleep while breastfeeding. Is this a problem, allowing children to fall asleep when breastfeeding? Is this a problem? Is it a problem for the mother or for the baby? Can you hear me? Can you hear me now? So, I'd like to ask you whether you think it is a problem either for the mother or for the child to fall asleep when breastfeeding or with the help of breastfeeding.
We will talk about this tomorrow more, but there are many ways, especially with exclusive breastfeeding, that co-sleeping can be quite safe. That sleeping with a baby can be quite safe. Okay, but there's certain things moms have to do. But breastfeeding is one of the things that you want to make sure that they're doing. Talk less.
Toddler, not a baby.
Toddler. Mm-hmm. With a toddler?
Yeah.
Oh yeah, toddler. Awesome to breastfeed with a toddler. Yeah, awesome. And in fact, you know, I'll tell you this. I finally moved both of my kids out of my bed when they were 3 and 5. I moved them together because they were getting so big that I was waking up with a leg over my head every morning. So yeah, it's wonderful to do that. But again, not every mother likes that. So it's kind of like that's an option. But if it's working for you, yeah, I think it's awesome. I mean, if you look at countries like Japan, I mean, they sleep with their mothers until they're like 5. So lots of cultures actually do it. So yes, I actually think it's great. Oh, wait, got a question back there.
Συγχαρητήρια για την ομιλία σας.
Congratulations on your presentation. Allow me to ask you, what could we advise women who go through education? Now the lady has shifted into English, so you may listen to her directly.
Okay, I only got half that question. Yeah.
What about the bad feelings mother has when...
Μιλήστε καλύτερα ελληνικά για να μπορέσει να μεταφράσει.
Ωραία, ελληνικά. Έχει βγάλει τα ακουστικά, γι' αυτό μιλάω αγγλικά.
Okay, he will...
What about feelings? The bad feelings mother has when they breastfeed toddlers, about the 16 months old. What advice can give to these women about their bad feelings?
Okay.
While breastfeeding during the...
Yeah. I think when you start getting to 16 months old and the mom is starting to have bad feelings, we might ask her kind of why. Some moms actually really don't like the nighttime breastfeeding. They don't like the baby on them like all the time. And we actually, we have a nice book on that, but we're going to put a podcast up on my website actually next week at talking about what kinds of strategies you can use to kind of get babies to not breastfeed all night long. It could be that's one issue. I'd find out what's kind of bugging them. A lot of times it's the nighttime. But there's also the option of stopping, when you get a baby that old. And I think that's an option we need to put out for the mothers too. I had this mother write to me from Australia, and she told me, she was, had a lot of abuse in her background. She breastfed her first child for 2 years, and she breastfed her second child for 18 months. But she was at a point where she was hiding from her child because she didn't want to breastfeed. She was just hiding, like in the house, and this child is coming and looking for her, and she's hiding. And she felt horrible about that. And she emailed me and she said, what can I do about this? And so, we talked about some of the things. Well, let's figure out maybe what's triggering this, why you feel bad about this, and we problem solved a little bit. But then I also said to her, I said, you've done an incredible job here. You breastfed for 2 years, you breastfed for 18 months. I said, one other option is that you can stop. And that's all I said about it, because I wanted her to know that was an option. If she's feeling bad that she's hiding from her child, that relationship with the child is actually at that point, I think, more important. So anyway, I didn't hear from her for about 6 months, and she wrote me this huge long email. And she told me it was the first time somebody had told her it was okay to say no to something she didn't like. So for sometimes moms, if they're really feeling bad, that could be the best option. I would try to problem solve with them first, see if you can figure out something, because sometimes, especially the nighttime stuff, really can bug. Or a lot of moms, they hate it when their kid pulls their shirt up in public. What a lot of mothers learn is strategies to say, no, we do no-nos at home. They have a code word for breastfeeding, and no, you don't pull my shirt up in public. Because that's the thing with toddlers, you can talk to them when they get a little bit older. So here, have a toy until we get home. So there's some strategy sometimes, but the other option, if she's really feeling bad and she's feeling bad all the time, it's better for her relationship with that child, to maybe stop. Or to limit it, to maybe a couple times a day.
So you advise them to make a code with their toddler and have some feedings at home or when the night is come or something like that.
See, I actually can't claim credit for that. That's a Leche League piece of advice. But yeah, one of the things when we did a survey about this, about extended breastfeeding, is we asked moms, do they have a code word for breastfeeding? And almost all of them did. They had some little, new-news, na-nas, they had all these little words, these cute little words that were code. That said, so if the child said that, it wasn't embarrassing out in public because, back when we did our study, that was still very secret. So you didn't necessarily announce it outside, your friends and your breastfeeding support group. But yeah, they put some limits on it as they get a little bit older. That it's really reasonable to ask that they not yank up your shirt when you're in public. So again, I would find out kind of what is bothering her and kind of see if you can problem solve, but also have that other option. Yeah, and yes, code word is cool.
Thank you.
You're welcome. All right. I think you guys get to go home. Thank you very, very much for hanging in there. Do we have another?
Yes, thank you very much.